Good afternoon and welcome. Thank you for joining the Scleroderma Foundation's Patient Education Summer Series. Today's talk, Scleroderma Lung Disease, is our fifth event as we host our virtual university. My name is Kerry Conley. I am the Director of Programs and Services for the National Office of the Scleroderma Foundation. We are delighted to have today's speaker, Dr. Jerry Molitor from the University of Minnesota Medical School, joining us today. There's a lot of information to cover in today's talk, and I know this is going to be a jam-packed hour, so let's get started. First, some quick notes on today's event. If you are properly logged into today's webinar, you should be seeing the slide on the screen and hearing my voice. If you have dialed in to the event by phone, please turn your computer microphones down to avoid any sound feedback. Today's webinar is being recorded and this will be made available after its broadcast. The Scleroderma Foundation in no way endorses any drugs, treatments, clinical trials, or studies referenced in today's webinar. Information is provided to keep the listeners informed. Because the manifestations and severity of scleroderma vary among individuals, personalized medical management is essential. Therefore, it is strongly recommended that all drugs and treatments be discussed with the individual's physician for proper evaluation and treatment. This webinar is for educational purposes only. We encourage attendees to use the question chat feature opportunity on the sidebar. Team members from the national staff will be hosting a question and answer segment at the end of the presentation. Please note, we will do our very best to get through everyone's questions. I am delighted to introduce today's speaker, Dr. Jerry Molitor. Dr. Molitor is the Associate Professor of Medicine in the Division of Rheumatic and Autoimmune Diseases at the University of Minnesota Medical School. Dr. Molitor was previously Assistant Professor of Medicine at the University of Washington, as well as the Director of the Arthritis Clinical Research Unit, Associate Director of Clinical Research, and Head of the Rheumatology at Virginia Mason Medical Center in Seattle, where he worked alongside Dr. Daniel First. Dr. Molitor now heads the multidisciplinary scleroderma clinic at the University of Minnesota. He has been involved in over 60 clinical and translational research projects, including multiple clinical trials of treatments for features of systemic sclerosis, including Raynaud's phenomenon, digital ulcers, interstitial lung disease, and pulmonary hypertension. Dr. Molitor has been named continuously to the top doctors list in Seattle, the Twin Cities, and nationally from 2007 through 2020. He's also been the medical advisor to the Scleroderma Foundation's local chapters in Seattle from 2002 through 2007 and in the Twin Cities since 2007. Dr. Molitor will speak on current treatments for scleroderma lung disease and on the tests used to diagnose and follow severity of these conditions so that therapies can be optimally adjusted. Thanks for joining us today, Dr. Molitor.
Thank you, Carrie, for that very nice introduction. Hopefully everyone can see the slides in this strange new world of how we do this. I'm looking out and not seeing your faces, but I'm trusting that they're there. So with that, we'll move along here to first my disclosures. I have been an investigator, as Carrie said, on a great many trials, and the companies as well as the NIH who sponsored many of these most of these are listed there. I've also been a consultant either in the recent past or currently for these companies. I am also not advocating any specific drugs in any specific situation, but I do want to make you aware of the data that tell us that we do have treatments that have good evidence for efficacy today, and we'll go through that. So my objectives for this talk are first to review the spectrum of scleroderma lung disease. Secondly, to outline treatments for interstitial lung disease. Third, to outline treatments for pulmonary hypertension, albeit I will do this only briefly. And fourth, to explain the value of the main screening tests. And in fact, my greatest goal with this is to make sure that you understand why we ask you to do the screening tests we do and what the value of those tests really is. And so in a sense, I've turned this talk on its head from the way I would often give a talk where I'd introduce screening tests first and then tell you about new or evolving treatment options. I'm going to tell you about some of the, I think, fairly exciting improvements in treatment that we either already have or have on the horizon, and then talk about why the screening tests are so valuable in that context. So if we look at causes of dyspnea, which simply means shortness of breath, obviously lung disease is at the top of anyone's list, and that's what we're going to talk about today. But there are other important possibilities that need to be kept in mind. Heart disease, of course, across the United States and the world is a major cause of chest pain, but it's also a major cause of shortness of breath. And scleroderma patients are not immune either from coronary artery disease or from several types of what we call heart failure that may not be as drastic as that sounds, but nonetheless can cause some shortness of breath. And scleroderma hearts can have some thickening or fibrosis that can make you short of breath if it's severe enough. That's beyond the scope of our talk today, but it is important that you be aware of that. Significant anemia or very low red blood cells can also make you short of breath. Modest anemia rarely is enough to do this, but scleroderma patients, like other patients, can have bleeding events, particularly in the GI tract, that they're not aware of that can cause them to be quite anemic. And so this always needs to be considered as a possibility. Scleroderma patients also sometimes get inflammation of the muscles, and the muscles can be requiring enough oxygen that in addition to maybe feeling a little achy or a little weak, they may make you actually feel somewhat short of breath under certain circumstances. But usually that's something you can figure out because of the amount of muscle symptom. And then finally, deconditioning. And many patients would rather think that they are deconditioned than think that they have lung disease or heart disease. And it's always important that we're not sticking our heads in the sand and missing something that might increasingly be a treatable condition. So the types of scleroderma lung disease include, and I've bolded the ones that we're going to focus on today, interstitial lung disease, and then pulmonary hypertension, of which there are two major types that we'll discuss. The first is pulmonary arterial hypertension, also called WHO type 1 for the physicians trying to make certain distinctions. And then pulmonary hypertension secondary to chronic low oxygen, which is WHO type 3, and which is particularly important in the context of long-standing or severe interstitial lung disease. The bottom two are pulmonary veno-occlusive disease and pulmonary emboli or blood clots. We won't discuss those. They're relatively rare in scleroderma, but when things don't fit, sometimes your doctors will be wanting to get some expert opinions on these things to make sure that this isn't happening, the pulmonary veno-occlusive disease. And pulmonary embolus is usually more straightforward. If you've had a swollen leg and then you suddenly become markedly short of breath, there's a fairly specific form of a CT scan that can be done to make sure that this is not happening. So why do we do screening tests at all? Whoops, I flipped through a slide here unnecessarily. So survival in scleroderma. This is an old slide from data compiled by the British group, and it shows the percent survival as a function of years from diagnosis from pulmonary arterial hypertension in this orange line, and it shows a pretty grim line that only 50% of people are surviving at a year. And lung involvement without PAH, which would be predominantly interstitial lung disease, is significantly better than that, but not great, with 50% survival approximately after about 8 years. And then if you had no heart, lung, or kidney involvement, your survival was significantly better and much better out to as long as 6 or 7 years. Now this is data from basically over 25 years ago at this point. And we'd like to think we're doing better than this, and in fact we are. The data overall suggests we've improved significantly from this. But the general trend for your survival to be worse if you had interstitial lung disease than if you had no heart or lung or kidney involvement, and for your survival to be even worse if you have pulmonary hypertension remains. And despite some very strong improvement that we are seeing, those are still the tendency of the lines. So why do screening tests? We're going to circle back to screening tests, and that's going to be toward the end of the talk when we go through them in detail, but we screen because we think we can treat. So we now have multiple pulmonary hypertension therapies, alone and in combinations, that appear to be bending curve C towards better and better survival. There's also evidence, and good evidence now, that we have therapies that bend curve B. So curve B is doing significantly better, we think. And there are additional therapies for both pulmonary hypertension and interstitial lung disease in development. And this is actually one of the exciting things, is the number of therapies that are in development today is unlike anything I have seen in 20 years. And finally, there's good evidence that the sickest patient who contribute disproportionately to the ILD curve get a mortality benefit from stem cell transplant. So this is an aggressive therapy, but it is one that has helped many of those patients. We'll briefly go through those data. And there's increasing evidence that certain systemic sclerosis patients can even do well with lung transplant, which historically has been shied away from in transplant centers, but is being increasingly considered. So scleroderma interstitial lung disease, there are some certain factors that we know make us think about it more. The SCL70 antibody, also called the anti-topoisomerase 1 antibody, increases the risk that it may be found. Having the anti-centromere antibody actually decreases the risk, but doesn't make it unimportant to make sure it's not there. It's more likely in what we call diffuse cutaneous systemic sclerosis than in the limited cutaneous systemic sclerosis, or CREST variant of disease. But it can also occur in individuals who really don't have any convincing skin disease. And this is always a toughie. And we rely very heavily on good interstitial lung disease clinics to identify those of you who don't start off with any significant skin features. High resolution CT scans are diagnostic, and we now advocate HRCTs in virtually all patients with newly diagnosed systemic sclerosis. There are very few circumstances where we would say this wasn't important to do. And then finally, pulmonary function tests, which include both lung volumes plus DLCO, which we'll talk about in more detail, are used to monitor for stability. Well, there are increasing treatments for SSc-ILD. Cyclophosphamide has been around for about 20 years, and I'll show you some of the data that got us to where we use the drug. We use it very little today because we have other good options, but there are certain specific circumstances where I would still consider this, and where your doctor may want to consider this as well. Mycophenolate mofetil, also called Cellcept, and what I call Sunum Cellcept, Myfortic, which is sometimes more easily tolerated from a gastrointestinal standpoint, have good data for their use. Nintedanib, now called Ofev, is the only FDA-approved medicine for scleroderma interstitial lung disease, and I'll briefly show you the data that supported the phase 3 clinical trial and the FDA approval. Rituximab has been advocated, and there are some limited data supporting that, and I won't discuss that. Tocilizumab, also called Actemra, also has limited data for its use that suggests that it could be helpful in scleroderma interstitial lung disease, but I will not discuss those data. Autologous stem cell transplant I will briefly discuss based on the data from the Scott trial, because I think in certain patients with severe disease, this needs to be considered early on rather than waiting to see if everything else can help. And then lung transplant, there are very limited data, and we will not discuss in any more detail, but I will tell you that we have had here, and I know other centers have had as well, some recent good success with doing lung transplant in well-selected patients. So cyclophosphamide for systemic sclerosis ILD, this started really to gain a lot of interest when Barbara White back in 2000 published this really, really important paper that showed in a retrospective cohort of patients of hers and Dr. Wigley's and Dr. Wise at Johns Hopkins that individuals who received cyclophosphamide were more likely to have a good outcome at a median follow-up of 16 months in terms of stabilization or improvement in their forced vital capacity, one of the lung parameters. And they were 2.5 times more likely to improve than those who did not get cyclophosphamide. Also in the diffusing capacity, also called DLCO, 1.5 times more likely. And most impressive of all, they had improved survival with a median survival rate of 89% compared with 71% in patients who were not treated with cyclophosphamide. Now, this study was retrospective, and physicians are never as happy with a retrospective study as they are with a randomized, double-blind, placebo-controlled trial, because we know that we tend to select our patients based on characteristics that we haven't necessarily spelled out in the chart in a clear way that can be reviewed, and for what therapy we give them. And so our bias in terms of how we've decided to treat may be affecting the results and making things look better or worse than they would be if we randomized. And this slide is just a very quick slide courtesy of James Seibold. I got it from Dr. Seibold many, many years ago, showing the ground glass changes, this haziness in the lungs, and how that improved over a year in this particular patient after getting oral cyclophosphamide. So the scleroderma lung study, SLS1, was an attempt to do exactly that kind of study with cyclophosphamide versus placebo. So it was randomized, double-blind with oral cyclophosphamide. And the mean 12-month, that means average in a certain way that we average, 12-month forced vital capacity difference was 2.53%. That benefit persisted for 18 months, but then the curves closed, and there was no significant difference thereafter between the two arms of the study. Dyspnea, however, the sensation of being short of breath, did improve, and that improvement persisted at 24 months. And I show this slide here from the study. Dr. Tashkin was the senior author of this study, showing the amount of scatter in these data so that you can appreciate these individual study participants were not very different from each other, whether they got cyclophosphamide or placebo, in terms of whether their FVC tended to improve, their forced vital capacity tended to improve or deteriorate. But on average, when we do all the numbers, 49% of the cyclophosphamide study participants improved to some degree or another, up to as much as a 15% improvement, whereas only 26% of the placebo group improved, and 73% of them worsened, whereas 50% worsened in the cyclophosphamide group. What you can see, however, is that the majority of these individuals changed very little, a little bit for the positive, a little bit for the negative. And that's a pretty common thing that we see in scleroderma lung disease. Nonetheless, if we can stabilize you, as clearly happened here with the cyclophosphamide, that's a good thing. These folks had just a very slight increase in the forced vital capacity percent predicted, and it got pretty good at 18 months, and then it dropped back off. And what this tells us is that giving cyclophosphamide for a year gives you some improvement beyond that point, but then you're either going to have to give it or something else again. Cyclophosphamide has real risks over time. It can damage the bone marrow and make secondary cancers likely. So we like it to get things under control if things are very aggressively going the wrong way, but we don't like it and really cannot use it as a good long-term therapy. And so because of that, some of us had already been looking at this, and these are data that my colleague Tony Gerbino and I generated while in Seattle, looking retrospectively again at some patients where those patients either could not tolerate cyclophosphamide or had had as much cyclophosphamide as we felt they should have because of those long-term risks, or simply worsened while on cyclophosphamide. And then we gave them mycophenolate mofetil. And what you can see here is that the overall trend from these what we call spaghetti plots of the people we put on mycophenolate is once we gave them mycophenolate, they tended to improve a little bit and then stabilize in general. And so this is a relatively small number of individuals. Several other groups published similar data, and based on those data, SLS2 was conceived. And SLS2 was a comparison of MMF versus cyclophosphamide. Because of the long-term risks of cyclophosphamide, the cyclophosphamide individuals got only a year of oral cyclophosphamide and a second year of placebo, whereas the MMF individuals got 2 full years of MMF. Despite that difference, individuals in the MMF arm had lower toxicity, although the treatment arms had equivalent efficacy. And in retrospective analysis later on, it was discovered that frequent cough also improved in tandem with forced vital capacity and gastroesophageal reflux symptoms, an interesting aspect of this particular trial. And here, once again, you see these nice data that largely recapitulate the data that we're seeing in SLS1 for cyclophosphamide, where people tended to keep improving out to here. Then they dropped off a little bit. Interestingly, the mycophenolate group looks like it might have dropped off a little bit too, but that's probably not enough to be important. It's certainly not enough to be statistically significant. These up and down bars give you the statistical significance. And as you can see, these groups are essentially overlying each other in terms of efficacy. So the nice thing about this is that we know that mycophenolate, as a drug that's been used in solid organ transplants, can be taken safely for long periods of time, with the primary risk being the risk of infections during that time, which is the same as with cyclophosphamide, which also carries similar risk. Well, the new kid on the block as of the last year is nintedanib, or OFEV. And this is a monumental trial where over 500 individuals, 288 on placebo, 287 on nintedanib, completed or were entered into the trial, of which almost exactly 500 completed the trial. And once again, you see in these plots individuals and how they did, adjusted rate of change in forced vital capacity per year. And you see there's a huge amount of clustering here near their baseline level. But I hasten to point out to you that most individuals entering this trial and other trials with interstitial lung disease are getting worse. And so if we can stabilize them, that's a good thing. And that is essentially what happened in the trial, is that individuals who got nintedanib measured out to 52 weeks were much more stable in their loss of volume measured by forced vital capacity in milliliters than those who were on the placebo arm. But this trial had a very interesting twist that turned out to be something that we're actually able to analyze. And that is, the trial allowed people to remain on mycophenolate if they were on it as a background medicine. And strikingly, the numbers came out in such a way that it's almost as though we set the trial up to compare the nintedanib and mycophenolate in combination and independently with each other. And I want to point out some things in this slide. Now, it is very important that I point out that some of the comparisons, if you compare these numbers, are not statistically significant. And so we cannot say with great confidence that these numbers mean everything that they might appear to mean. But I do want to point out some things and give you why I think this is just a very positive thing that we're seeing here. So if you look at the annual rate of decline of volume in any of our lungs who have healthy lungs with no known lung disease, it's about 20 to 25 milliliters. That's not very much volume, and you can easily lose that much volume per year over your lifetime and never feel it. If we look at all of the study placebo patients who did not get nintedanib, they drop about 94 milliliters over the course of a year. So approximately 4 to as much as 5 times the amount that a normal lung would lose. However, if they were on mycophenolate, the severity of that drop was diminished, and it was on the order of 64 milliliters. But if they were on neither nintedanib or mycophenolate, it was worse. It was 119. Again, these comparisons are not necessarily statistically significant. I did not put in the data to tell you which comparisons would be statistically significant here. But you can see the evenness of these, because this was not done intentionally. The nintedanib positive individuals who got the study treatment arm did much better, lost only 52 milliliters, or approximately twice what historically normal lung control would per year. So you might say, well, that's not very good, but indeed it's much better than not being on anything, and it's better than the it's numerically better than those on just mycophenolate. But it turns out that if you look at the nintedanib individuals who were not on mycophenolate, they were about the same as the mycophenolate individuals who are not on nintedanib. So based on these data, and again, this was not designed to compare the drugs directly, but it looks like they both can give benefit. And here's what I consider the most
Oh, Dr. Molitor, this is Kerry. It seems like you're breaking up just a little bit.
now, and it's down to where it's less. Okay. Can you hear me now?
Yep, perfect.
Okay, not sure what that was. Um, what I think is quite exciting here is that if we look at the nintedanib plus mycophenolate, and again, these numbers are not big differences, but it looks like we're getting down to where we're losing less than twice what our natural volume would be in individuals without disease. And what I take from this, and I know for a fact that some of these individuals could not be on full doses of either of these drugs because this can be a hard combination to tolerate. What I take from this is that with many of the new things we have under development, we may be able to do even better than this with combinations of drugs, as we do today in rheumatoid arthritis. And so I find this a very exciting development, that drugs with different mechanisms of action can show benefits that appear to be greater taken together than either drug by themselves. Well, I want to talk briefly about the stem cell transplant studies, and I'm going to go through this very quickly, but the Scott trial was published now several years ago. And this was a trial where we compared myeloablative, meaning we wiped out all your white blood cells and then gave you back stem cells that had been selected with what's called CD34 selection, versus giving you cyclophosphamide for a year, which we knew could give you a benefit as well based on the prior cyclophosphamide studies. And when we look at what's called the global rank composite score primary endpoint, which gives a hierarchical ordering of mortality, which we would all agree is the most important thing, I think, and then event-free survival without organ failure, which is defined down here, and I'm not going to go into it in detail for the sake of time, and then lung function with improvement or deterioration in forced vital capacity of more than 10% from baseline. And finally, the SHAQ, which is a measure of quality of life, and the modified Rodnan skin score, a measure of skin severity. And what this slide shows you, and I'm just going to ask you to focus on the colors because there's a lot of data embedded in here and we don't have time to go through it all, but is that there were more deaths in the black boxes here in the cyclophosphamide group than there were in the transplant group. There were more individuals who met the endpoint of meeting the required drop in lung function or one of the other organ manifestations. And the lung functions are in red. And so you can see that the lungs contributed disproportionately to the worsening in the cyclophosphamide group compared to the transplant group. And then you see improvement over here in forced vital capacity in transplant versus over here in cyclophosphamide. So clearly transplant did better for the lungs. And that's what we've seen. And I've followed several of these patients, and this is borne out in those individuals. So transplant for the sickest patients, and these were only very sick patients with very bad disease really in this trial, which is why there's a lot of deaths because the disease was so bad. But nonetheless, if you look at transplant, the result was clear that this improved things for more people. So in people who are really sick, it's an important option. Well, here's this slide is not to teach you about all these, and I'm not even going to read them in the interest of time. It's to make the point that there are so many clinical trials going on right now. This is not a comprehensive list. And so we have a lot of new kids on the block who may make big differences the way that we've already seen happening now with nintedanib. And I'm more optimistic than I've ever been that we're going to see good therapies for this disease. Well, moving on to pulmonary hypertension, we've already introduced group 1, pulmonary arterial hypertension, which can be associated with connective tissue disease, which in our case means scleroderma, and group 3, which is due to chronic lung disease and or chronic hypoxemia. There are some people who fit better in group 5 that are likely multifactorial, and a few scleroderma patients can have chronic thromboembolic disease, and we won't discuss that. The prevalence is 10 to 15% of systemic sclerosis patients. It remains the leading cause of death, but the 2-year survival rates seem to have improved, as I've shown you here, compared to go et al. The serology shows an increased risk if you have the anti-centromere antibodies, the anti-U1 ribonucleoprotein antibodies, or just a nucleolar pattern, which is pretty nonspecific. Systemic sclerosis patients with SCL70 antibodies are more likely to have their pulmonary hypertension due to chronic hypoxia from interstitial lung disease. And several screening tests are used to determine the need for right heart catheterization, which is the gold standard to make the diagnosis. And in the interest of time, I will not talk about right heart caths. I'm going to go quickly through the pulmonary hypertension specific therapy. CCBs are almost never used in scleroderma patients, but I have them on here for completeness. There's the endothelin receptor antagonist, bosentan, macitentan, and ambrisentan. There's the phosphodiesterase 5 inhibitors, sildenafil and tadalafil. There's a drug called the soluble guanine cyclase stimulator, or riosquat. There's the possibility of combining an ERA plus a PDE5 inhibitor, and the best data are for using ambrisentan together with tadalafil, which was shown in a nice study with cardiac MRI to improve the heart function in patients with pulmonary hypertension, which is the critical component for efficacy. And then there's epoprostenol, iloprost, trepoprostenol, and selexipag as prostacyclines, which are delivered in a variety of manners from IV, sub-Q, and even inhaled for iloprost. I think that may be a duplicate. WHO group 3 pulmonary hypertension, there's a critical point that I wish to make here, and that is the pulmonary arterial hypertensions don't work as well for these patients. We don't know exactly why, but it's an important fact. And keeping the oxygen saturation levels normal is critical. So above 90 to 93% is really a big deal if you have WHO group 3, or otherwise it tends to worsen. ILD patients with more extensive disease, who have obstructive sleep apnea as well, and who are living at altitude are at increased risk because of low oxygen tension at increased altitude. And controlling these factors is critical. Oxygen is probably the best medicine for this, although that's a very hard thing to study and prove. But based on what we know about chronic hypoxia worsening the problem, we think that that's the case. And therefore, it is good to be tested by your doctor to make sure you don't need supplemental oxygen. And you can, these days, test yourself at home with a pulse oximeter. Now, most pulse oximeters are worn over the tip of the finger, and that's problematic if you have Raynaud's, because the tips of your fingers are often blue, and it doesn't read that very well. But if you get one of these kinds of oximeters, and I'm not advertising for this company, I don't even know which company it is. I pulled this off of the internet because it was a good picture that gives you the idea of how you can wear this further back on your finger. So they may be more accurate if you have active Raynaud's. Well, let's move on to evaluation, because this is the part that I consider so critical, because this is somewhat under your control in terms of making sure that you're getting the kind of evaluation that's going to let your doctor identify whether you have interstitial lung disease, pulmonary hypertension, or both. So history and exam are very important. Taking a good history for those of us who are your physicians gives us a sense of whether you're physically active and are not having any trouble with your breathing, or whether you're so physically inactive that you can't really know whether you're having a lot of problem most of the time, or whether you're really having a lot of trouble and you can tell us that. Dry cough, for example, that's persistent is a concern for these lung diseases, although it may simply mean that you have bad GERD that's not under control. The HRCT we've already discussed and is now considered the critical diagnostic tool to identify ILD. Pulmonary function tests are non-invasive, although they're a little bit difficult now in the coronavirus era because you can't do very many of them in a day because all the materials have to be cleaned in between patients. But as long as we do them including FVC and DLCO, we get a good deal of information, and we can usually assess if you're stable by watching those closely. The echocardiogram is a critical tool for assessing for the possibility of pulmonary hypertension and referring for right heart catheterization if necessary. 6-minute walk test measures whether your oxygen saturations diminish with a walk, how far you can go, and whether you get short of breath when doing so. And finally, there's a blood test called the Pro Bnp, or sometimes just the BNP, that can be helpful. Well, I'm going to go briefly through the tests. So spirometry, what does it measure? Well, first it measures how fast you breathe. And that's the FEV1, the forced expiratory volume in 1 second, which is not something we concentrate on a lot. And then the FEV1 to the FVC ratio. But it also measures how much you breathe, the forced vital capacity. And we concentrate a great deal on that for considering interstitial lung disease. So spirometry is basically a simple expression of a complex process. It looks at your airways, it looks at your parenchyma, which just means the lungs themselves, the chest wall, if you can't expand your chest wall because of some other condition, the respiratory muscles, which can be affected if you have myositis, so any anatomic abnormalities. So if you have bad kyphoscoliosis of the spine, for example, you can't breathe normally. And then your body mass index. So are you carrying a lot of extra weight that's pushing up on your diaphragm here and pushing in to make it hard for you to take a deep breath? The predicted values for these are determined in part by your age, by your gender, your height, your race and ethnicity. And these values are normalized somewhat in a long-standing study called the NHANES 3 study that we won't go into. And this silly picture is simply to emphasize that if you're old and frail is a little different than if you're a robust soccer player. And so spirometry goes through what's called a flow volume loop. And it's simply a graph that represents how fast the air comes out of the patients. And airflow rates themselves are proportional to airway caliber. So that's how big your airways are, which is not usually an issue for scleroderma patients. So this here is your forced vital capacity. It's how many liters you can do. And this must have been that soccer player because that's a big forced vital capacity. And this is a normal lung that goes straight down like this. So if you have obstructive airway, which we're not really here to discuss today, but you may get concerns about your FEV1. Your FEV1 goes down if you have chronic obstructive lung disease, which you might have if you're a smoker, or asthma. And if you have restrictive lung disease, your vital capacity and forced vital capacity values will change the shape of this curve that I'll show you in a second. If they're too small, they have to be confirmed with lung volumes plethysmography, which I'll show you a picture of in a minute. With interstitial lung disease, there's restriction of the lung volumes, FVC and vital capacity are reduced. So here's a somewhat normal flow volume loop. And you can see here that this is your FEV1, how much you breathe out in a second. And then if you have a restrictive lung disease, interstitial lung disease is one type of interstitial of restrictive lung disease, how this volume drops, it goes down. And so that's what we see with bad restrictive lung disease, including interstitial lung disease. Well, the lung volumes are measured by body plethysmography, and some of you have had the joy of sitting in one of these. I did it myself, so I knew what was going on. It's a little rough if you're claustrophobic. The newer ones are better because they have a lot of windows. Patient does the breathing maneuvers in a closed body box. This gets at what we can't measure with spirometry, which is called the residual volume, and that's important. And then it helps us to accurately determine lung gas exchange with diffusing capacity by being able to estimate what the volume of all your alveoli put together is. So diffusion capacity is what? This is a critical measure for us to understand, to consider the possibility that you have interstitial lung disease or pulmonary hypertension because they behave differently. So this measures transfer of gas from the alveoli to the red blood cells. So here come the red blood cells in, and they're blue because they're not carrying much oxygen, they're mostly carrying carbon dioxide. And they release their carbon dioxide into the air sacs called alveoli. And the oxygen that's coming in then passes across this very thin membrane into the red blood cell and turns the red blood cell a bright red. And the oxygenated blood goes out and goes back to the heart, where it gets sent to your brain and all the rest of your body. And this is affected by the red blood cell count. So if you're anemic, your diffusion capacity appears to go down. It's affected by the time of day. This changes as the day moves on. It's changed by smoking, by exercise, and by high altitude. So each of these things is important to track when we're doing the study. It's usually decreased commensurate with volumes in interstitial lung disease, unless the ILD is very early and very active, in which case it may look worse than the volumes, and more than by volumes in pulmonary hypertension. So the DLCO much lower than the volumes always worries us for pulmonary hypertension. It's unreliable in advanced ILD with low lung volumes because it requires the ability to purse the lips to seal the mouthpiece and hold your breath for 10 seconds. Well, moving on to the 6-minute walk test, which many of you have done, I am sure. Excuse me. This measures the distance, the shortness of breath that you tell the evaluator that you experience, and the oxygen saturation. It's useful for both ILD and pulmonary hypertension assessment, but it doesn't distinguish a reason for why you aren't going the distance that you might if you're having oxygen desaturation or if you're dyspneic. Pulmonary hypertension treatments have in general been approved primarily by the FDA based on differences in distance walked on this metric. And that's problematic in systemic sclerosis for some patients who really can't necessarily walk well because of other parts of their musculoskeletal manifestations of disease. Oximetry appears to be the most reliable metric in systemic sclerosis patients of all the metrics in this test, but it requires a forehead probe for your oximetry. If we rely on a fingertip probe and you have Raynaud's, that's not very reliable. And earlobe probes may or may not be preferable based on the results from several different studies. So we like to see a forehead probe always used. And that's something you should be keeping track of. If your center isn't giving you a forehead probe, that they may be getting inaccurate information. Sorry, this fade in was a little goofy. So moving on to echocardiograms, I suspect that the vast majority of you have been given an echocardiogram at some point. This measures not only heart function, but also whether the valves are leaky and what that might mean. So it allows us to measure how well the atria and ventricles squeeze, how well they relax, if the valves leak, and if a leak across the tricuspid valve in particular, which separates the right atrium from the right ventricle, is severe enough to suggest pulmonary hypertension. And you see that here, where the right ventricle and the tricuspid valve leaks enough that it allows us to see this blood flowing backwards from the ventricle into the atrium. The red means it's flowing towards that direction. And that is significant pulmonary hypertension there. Oops, excuse me. Well, we've learned to add together our different tests. So in this study, this is an example of how we do this clinically to decide whether or not you need a right heart catheterization. So an estimated right ventricular systolic pressure by echo of less than 45 millimeters, which for a while was considered the threshold to do a right heart catheterization. You had to be over 45, missed up to 22% of the pulmonary hypertension cases when you actually did a right heart cath. About 70% of those individuals were correctly identified by using this ratio of percent forced vital capacity to DLCO that I already discussed. Now, if you combine the two factors together in what's called a decision rule that I'll talk about in a minute, and use 35 millimeters of mercury plus this ratio of greater than 1.6, this had what's called a positive predictive value of 0.433, but importantly, a negative predictive value of 0.978. We always like high negative predictive values because it makes us confident that if we have a very high value, that we're not missing a critical diagnosis like pulmonary hypertension. So we would say that if you were below 35 and had a ratio better than this, that we wouldn't miss pulmonary hypertension based on this decision rule. Now, in fact, most of us, I think, would be very careful about even a PA systolic pressure estimate greater than 30 today. but we don't need to get into the details. This is simply to show you that sometimes you may wonder, why are we ordering so many tests? Well, we order the tests we do because combining them together gives us more information than taking any one of them by itself. So a clinical decision rule is a decision rule. It's derived from original research and may be defined as a decision-making tool that incorporates 3 or more variables from history, physical examination, or simple tests, such as those we've just shown you. It allows risk stratification for the evaluation and management of presentations with a risk of poor outcome, like pulmonary hypertension. It limits testing that would otherwise risk adverse effects. So right heart catheterization in specialized high quality centers, such as the one I'm at, is a very safe procedure done in skilled hands. But it's tricky and it requires skilled hands. And so I wouldn't undergo a right heart catheterization personally if I didn't think I needed one. And so that's where these decision rules and getting all the testing up front that says this is worrisome, we should do the right heart catheterization, rather than just doing right heart catheterization on everybody who's short of breath. Then we can standardize the approach to difficult to diagnose conditions, especially for individuals with less experience evaluating them. It's all fine and good if your doctor has 30 years of experience and they say, my instinct tells me that you should have a right heart cath. And they may be right most of the time because they may be weighing all these things in the back of their mind. But if somebody who doesn't have that much experience has to evaluate you, these are very helpful. And it allows us to perform additional testing as needed to make a better prediction. So NT-Pro Bnp is the last of these tests I'll talk to you about. Both BNP and NT-Pro Bnp are measures of stress on the heart wall. Many physicians use them because they have been shown, if you have significantly elevated levels, together with the other screening tests, in decision rule algorithms to help decide when to perform right heart catheterization. Just so you know, they are also used to diagnose heart failure and exacerbation of heart failure, typically with much, much higher levels. These are big numbers when heart failure is involved. There's some disagreement about whether one test is better than the other, and many centers only do one of the two. And your doctor may feel the other tests that I've already described are adequate to decide for or against right heart cath and never even do this. So a couple final slides here. I want you to be aware of SSPD, sneaky subclinical progressive disease. This is my own silly little thing, but it's the issues arising here are not silly. So are you inactive with little ability to monitor your exercise tolerance? I worry a lot less about my patients who tell me that they run 5 miles 3 days a week and they can do that distance in the same amount of time as they did it 5 years ago than the ones who tell me they're really not sure because it hurts their feet too much to walk for more than 100 yards. Have you never had a high resolution CT scan? There certainly are patients out there who never have. 10 years ago, this was not routine to always do high resolution CT scans. And some centers may still be practicing without doing these. And I think that is changing. Is your doctor only ordering spirometry? I see this a lot where we don't get a DLCO, and the DLCO, as I think I've convinced you, gives us a huge amount of information. Are you missing appointments or tests because of costs or COVID-19? This is a big concern for me right now. It's more difficult for us to do pulmonary function tests. We're deferring them on people, and that's probably okay if they feel stable and they're pretty sure that they're stable, particularly if they've had their disease for a long period of time, because it's less likely it's progressing. But if they don't feel stable, we need to figure out how to evaluate them. Are your PFTs slowly dropping, but you're not having the other tests to figure out why? That's a concern. Your 6-minute walk test isn't done due to an inability to walk. That's a major issue for some of our patients, and the test just isn't of value. And finally, are you blaming being out of shape for worsening exercise tolerance? So here's a hint. If you get short of breath climbing 1 flight of stairs, that's not good. So what should you do? What are you in good control of here? Well, here's a few thoughts. So number one, exercise as you are able after clearing with your doctor. We don't want people with bad coronary artery disease trying to suddenly start running stairs. That might not be so good. But otherwise, exercise is good for your lungs. Inform your doctor if your exercise tolerance drops. So if you're quite sure that you used to be able to walk around the block briskly and be done, in 10 minutes and now it's taking you 15 and you're really struggling, we want to know. If you have a new persistent dry cough, that's a concern. That can mean active lung disease. If you have new or worsening leg swelling, if it's just one leg, that's a concern for a blood clot, particularly if it's also painful and red. But if both legs are swelling, that can mean your right heart's under significant strain. If you're you should repeat your screening tests as recommended, and typically most of us would say you at least need to have pulmonary function tests annually, if not other testing. Ask your doctor about a home oximetry device. If you're short of breath with routine tasks, you may have low oxygen saturation and be at risk for WHO Group 3 pulmonary hypertension. And knowing that would be important, and then having what's called an oximetry titration to decide whether you should be on oxygen. Now, nobody wants to be on oxygen. My patients are really not happy about having to be on oxygen. But if it stops you from getting significant WHO Group 3 pulmonary hypertension, you'd have to decide whether you think that's worth it. And I think for most people it is. Even if you don't want to wear it when you're out in public because it's embarrassing or difficult, if you wear it most of the time when your oxygen saturation is low, it would be helpful. And inform your doctor if you can't afford or can't tolerate your medicines. We want to know. Maybe we can help. Maybe we can find an assistance program. Maybe it's a medicine that you're just never going to be able to take. Maybe, as sometimes the case with nintedanib or MMF, or myfortic, if we just give you a little bit of Imodium to control what sometimes is the big side effect of loose stools, you can continue to take the medicine and benefit from it. We need to know if we're going to help you. And finally, consider participation in clinical trials. You may or may not help yourself, but if you help the entire scleroderma community, we may all get some new and better therapies. And we keep learning about how these things help each of you for a long time after they're approved, because we start noticing other things that may be helped by the medicine that was really only approved for one aspect of the disease. So with that, I'll take some questions. This is our dog Ginger. When Ginger asks a question, this ear comes up. Usually the question's about food, but we'll plan on other questions from you all. And so I thank you from what was 3 hours ago, sunny Minneapolis that looks something like this. It's getting a little cloudy now, but this is a kind of a lovely picture of the way it looked this morning. I didn't take it, but that's sort of the way it looked. So thank you all.
That is a lovely picture and great presentation. It's great. It looks like we have attendees have taken the opportunity to ask a few questions. We have the National Team Office members, David Murad, Director of Chapter Relations, and Angel Soto, Programs and Services Associate, here to facilitate the segment.
Good afternoon, everyone, and thank you for that wonderful presentation, Dr. Molitor. We do have quite a few questions, so I'll just get right into it. First off, with so many treatments available, is there a treatment that you feel better about at early stages of lung disease, or are there some that you just feel are better for late stage?
Well, first off, I would say that we need to break that down a little bit. So early stage interstitial lung disease, early stage pulmonary hypertension are fundamentally different in terms of the treatment choices. And early isn't as important as severity. So I did not go through for the group, but if you come to us and your lung disease is early, but it's interstitial lung disease that's already affecting more than 20% of your lungs on the HRCT, that has a much more severe prognosis than if we do your HRCT and we can find some little wisps that look like they're interstitial lung disease. So in a person with little wisps that look like they're interstitial lung disease, I would typically probably just start that person on some MMF and see how they do. Now, nintedanib really is changing the equation of what we decide to use first. And I have expert interstitial lung disease doctors working side by side with me who have lots of experience with nintedanib because it's been approved now for several years for IPF. And so we confer constantly about which drug may be better to start in a person with relatively mild disease. In a person with more severe disease, we have to assess, do we think their disease is bad enough that we need to start them right away on a combination of those two drugs, see how they do, or even consider cyclophosphamide, which we use fairly rarely anymore. And in a person who progresses rapidly despite those things, which fortunately is quite rare today, that's the kind of person who I would consider sending for a stem cell transplant evaluation. So it's not so much whether it's early or late as it is severity that helps us decide how aggressive to be with the medicines.
The next question. Well, what is the difference in pulmonary hypertension versus pulmonary arterial hypertension? Could I have both, or are they the same?
So pulmonary hypertension is the big category of all of the forms of pulmonary hypertension. Pulmonary arterial hypertension, which is WHO group 1, the WHO group 2, which is due to chronic left heart disease, such as people who've had multiple heart attacks or other problems with the heart globally would have. The WHO group 3, which I talked about, due to chronic hypoxia, the group 4 due to chronic thromboembolic disease, and the group 5, which is multifactorial. Pulmonary hypertension per se, all of these forms of pulmonary hypertension are diagnosed primarily based on hemodynamic characteristics of the right heart catheterization, which you'll note I didn't talk about at all. It is very complex. It's hard to go through in a quick way in a talk that is trying to cover the entire landscape of scleroderma lung disease. So I decided not to try to explain it because I didn't think I could do it justice. But pulmonary arterial hypertension is simply one form of the global category of pulmonary hypertension. It's diagnosed by right heart catheterization after the screening tests we discussed have led us to believe that it could be there. And the treatments that work for it all those treatments I showed you tend to improve the vasodilatation or opening up of the blood vessels and improve the squeeze of the right side of the heart to help handle that. Whereas the other pulmonary hypertension types may not respond as well to that kind of medicine.
Thank you. So are all patients with esophageal dysfunction automatically ruled out to qualify for lung transplants? And if so, why is that?
So that's a great question. And I would say that the severity of esophageal dysfunction is a big issue for lung transplant. And it's a big issue because if you chronically have contents from the stomach spilling up through the esophagus and over into the upper airways of the lungs, and we give you a lung transplant, and the lung transplant requires a lot of aggressive immunosuppression to keep your body from rejecting those lungs. So if you're then spilling the contents from the stomach over into those lungs, that can cause chemical irritation, but even worse, it can bring bacteria and fungus into the lungs that are so immunosuppressed, and then a dangerous and even fatal infection can get started. So there has always been a lot of concern about doing lung transplants at all for scleroderma patients. Well, we've done several successfully recently with patients who are very, very rigorously adherent to recommendations. It's really important that if the evaluation shows a degree of esophageal risk that we think may be acceptable, but only acceptable if you don't eat for a fairly long period of time after the transplant, and that what that means is variable from person to person, but that you be willing to comply with those recommendations, or that's where we are most concerned that we lose people. So it's very individualized. Different centers have different protocols that they go through to make sure they're convinced that this is safe in their individual patients. So it's not a sure thing that you'd be considered a good candidate, but there are centers now who are doing this. And in those carefully selected patients, it looks like scleroderma patients don't do any worse than anybody else.
Thank you. Next question. Will all systemic patients eventually develop lung disease? I'm newly diagnosed with severe GI issues.
The answer is no. As I showed in the pulmonary arterial hypertension slide, only 10 to 15% of people appear to get pulmonary arterial hypertension. Even in the highest risk groups of individuals who are topoisomerase antibody positive with diffuse cutaneous systemic sclerosis, less than 50%, fewer than 50% of them do get at least clinically significant interstitial lung disease. So there are many patients, most patients don't get pulmonary hypertension, and most patients don't get interstitial lung disease. Very few limited cutaneous systemic sclerosis or CREST patients get clinically significant interstitial lung disease. Some do, and that's why we now advocate that we always check the HRCT unless the overall picture is just so unlikely that we don't think it's we think it's almost a zero chance. But in general, we now advocate that people get that done. But those individuals with CREST or limited cutaneous systemic sclerosis are quite low risk for ILD. Although I should hasten to add, they are at higher risk over time for pulmonary arterial hypertension, so they still need the screening tests.
Perfect. So during this pandemic, with so many of us getting our pulmonary function tests and screenings delayed, how long is too long to have these tests delayed?
Yeah, that's a really good question. I think it depends a lot on where you're at in your disease process. So if you're a patient who's never had lung disease and you've had your disease process for 5 years or more, and you are doing things, certain kinds of exercise, and you know what you can do in a given length of time, that exercise tolerance that I talk about, I think is a big thing. So if you know that you can do a certain amount of exercise in a certain amount of time and that you're completely stable from the way you were 2 years ago, I think it's fine to defer pulmonary function tests as much as an extra year out. And that probably, hopefully, will get us through the critical time of this pandemic. If, on the other hand, you're early on in your disease process and you had your first evaluation and the doctor said, well, I'm not sure that it's meaningful, but it looks on the HRCT like there might be a little bit of something going on at the base, and I think we should probably repeat that next year. And in the meantime, we should do your pulmonary function tests every 3 to 4 months. And now you haven't had pulmonary function tests for 9 months and you have a dry cough and you think you might be more short of breath. You should not just wait in patients. In my opinion, you should be contacting your doctor and saying, I think I may be getting worse. Can we take another look? You know, even when we were most closed down, when we really didn't know what we were looking at, and we were trying to keep people out of the buildings as much as possible to make sure we didn't wind up with a situation where we had so many people in the ICU like they did in Italy that we couldn't take care of people. Even during that time, we were doing HRCT scans on people if we thought they needed it. We weren't doing pulmonary function tests, but we would do HRCT scans. And if you have interstitial lung disease and your disease is clearly getting worse, that will tell us that. Similarly, if you have clearly developing pulmonary hypertension, the echo alone can usually show it. It's in these softer cases where we use the combination of tests and the decision rules. And it's a great way to practice when we can. If we have to defer the pulmonary function tests, but things seem stable, I think that's okay.
Thank you. Next question. I worry about the side effects of many of the drugs to treat lung disease. Do they put me at a greater risk to get cancer?
Very good questions. So, as I said, cyclophosphamide definitely does increase risk of cancer. Probably if you have less than 6 months total exposure to cyclophosphamide, that risk is pretty low. Unless you're a cigarette smoker, in which case your risk of bladder cancer is actually pretty high. And so the combination of tobacco use and cyclophosphamide really presents a pretty high risk to the bladder. And anyone who's had significant cyclophosphamide exposure, and a lot of doctors miss this, should be having a urinalysis at least once a year, and most people would say once every 6 months for the rest of their lives, to look and see whether there's a lot of blood coming through, and if there is, to make sure that there's a good look to make sure there's no cancer up in the bladder. That's the one type of cancer. The other type of cancer that tends to happen more if you've had multiple exposures to cyclophosphamide that in aggregate come to several years of exposure is myelodysplastic syndrome and even leukemia. That risk accumulates over time, and that's very significant. And it's one of the reasons I don't like using a lot of cyclophosphamide. The other reason I don't use much cyclophosphamide now is if I think a person is sick enough to need cyclophosphamide. I do think it works. The data from SLS1 were not very convincing, but that goes to some funny things about clinical trials. People were so impressed by the Barbara White, Fred Wigley data and Wise data that they were, on all their sicker patients, they were just using cyclophosphamide. They weren't putting them in the trial. And so we were only seeing patients with less severe disease in the trial, and they couldn't therefore improve as much. That's my bias of interpreting that trial. So, but I will say that if you've had more than 3 to 6 months total exposure to cyclophosphamide, you're no longer a candidate for stem cell transplant. And that means if you have really bad disease and you would benefit from stem cell transplant, now you're out of luck. So I'm very careful not to give people more cyclophosphamide than that. The other drug that deserves consideration in terms of the cancer question is Cellcept. There's a close cousin to Cellcept called Imuran that we know significantly increases risk of skin cancer and may increase risk of other cancers somewhat. Cellcept doesn't appear to be quite as bad in that regard, but it may slightly increase risk of cancers. And this is because the immune system actually monitors for and kills cancers when they're really small. That hasn't shown up to be a big issue with Cellcept, however. So I'm not afraid of Cellcept in that regard, and I don't think you should be either.
Thank you. So we know that having interstitial lung disease, or PAH, leaves us at a higher risk of getting COVID-19. How much higher is that risk?
We don't know. The most correct answer is we don't know. I'm not sure how much higher your risk of actually getting the virus is from having any aspect of scleroderma. It may well be that a drug that's immunosuppressive like Cellcept or MMF does increase your risk somewhat, or cyclophosphamide if you happen to be on that one. Nintedanib, as far as we know, probably does not increase risk of infections. There's no evidence of that. And so in that sense, it may be a preferable choice at this point in time. But the real risk is probably not contracting the virus so much as the risk of becoming very sick from it. If you already have a sick heart or sick lungs or a sick vascular system, this virus appears to be significantly more dangerous for you. So what I've been advising our patients is you need to be extra careful. You know, even if you're the social butterfly of your group, you really have to cut down on all those interactions. And you need to ask your family and friends, the people that spend time and are close to you, to likewise be cautious so that they're not bringing the virus into your home and putting you at risk.
Thank you. So for those of us that can't get to a scleroderma center for these evaluations and treatments, is supplemental oxygen an effective treatment for managing PH?
Well, if your oxygen levels are low, you should be on supplemental oxygen. If your oxygen levels are frequently or consistently below 90%, yes, you should be on supplemental oxygen, because the pulmonary hypertension will tend to worsen without it. And eventually, the real problem with pulmonary hypertension actually isn't the pressure. Sometimes people get hung up on what the pulmonary artery pressures are. And the real experts in pulmonary hypertension are not hung up on those numbers. I mean, they certainly pay attention to them, but they care about what your right heart is doing. Is your right heart coming under a great deal of strain? Is it starting to show signs of what we call failure, where it just can't squeeze out the blood? And when that happens, that's bad. And people don't do well at that point. And so to the extent that the oxygen can keep that from happening, yes, you want to be on oxygen. One of the reasons I showed you what I showed you is for the people who don't live close to a specialized center, so that they can be asking their doctors to do the things that are frankly not very hard to do anywhere. The 6-minute walk test can be done almost anywhere. An NT-Pro Bnp result can be drawn at almost any lab and sent in to a reference lab if the lab there locally doesn't do it. And most places can do good pulmonary function tests that include not just forced vital capacity, but DLCO. And echocardiograms are a little bit variable. There has to be a good cardiologist who can read them, but you usually can get a decent echocardiogram at most moderately sized medical centers. At least one that's good enough to make sure that your PA systolic pressure estimate isn't really significantly elevated, like 40 or higher. They can usually pick that out. It's skill dependent, and some places are better than others, but it's not a reason not to even try to get it done, I don't think. And HRCTs can be done almost anywhere that has a CT machine.
Thank you, Dr. Molitor. We're about 11 minutes past the hour, so just to be respectful of your time and of the attendees, we're just going to ask one more question. So the question is, how soon do you think the new treatments that are in trial right now might come to fruition? Is this something that might take more than 10 years or less than 10 years?
Well, I'm certainly hopeful we're talking several new treatments in less than 10 years, and I think that's likely. There are drugs right now that are completing phase 3 clinical trials that are not necessarily all focused on the lungs, but there are so many drugs in development. My colleague, Dr. Hyen Kim, who sits right next to me from pulmonary, can't even begin to try to do
I'm sorry, Dr. Molitor. Your audio cut out for just a moment.
with multiple different mechanisms. Oh, I'm sorry. Yeah, I don't know what's happening when that happens. I'm sorry. Can you hear me now?
Yes, we can hear you now.
Can you hear me now?
Yes, can
Hello?
you hear us?
Okay.
Hello,
What I was
Dr.
saying is yes, I can hear you. You're still not hearing me?
Oh,
We can
Hello?
hear you.
You're clear now.
Hello?
We can
You got
hear you,
me?
Dr. Molitor. We can hear you.
So what I was
Yes.
saying was, okay, my colleague, my interstitial lung disease expert, who I sit right next to all the time, can't even begin to try to do all the clinical trials that are coming down the pike for idiopathic pulmonary fibrosis, which is the most common form of interstitial lung disease that nintedanib and another drug were approved for already several years ago. There are so many candidates now that deal with fibrosis, candidate drugs, and there are several candidate drugs that deal with inflammation in a way that has never been even thought of before. So we have so many good candidate drugs that some of this is just a matter of luck. You throw enough pieces of wet spaghetti against the wall, one of them sticks. But some of it goes well beyond that to several decades of good basic research that help us understand mechanisms of fibrosis and inflammation leading to fibrosis. And so many of these drugs are brilliantly targeted against certain aspects of that. And I think the possibility is very good that we would have a number of drugs that can be used in clever combinations ultimately to really bring a lot of the aspects of scleroderma lung disease and a lot of aspects of scleroderma as a whole under really good control. So I'm optimistic. I'm more optimistic than I've ever been. The pathway that I see is nothing short of astounding.
That's great to hear. Thank you, Angel and David, for facilitating such great questions. Dr. Molitor, any parting comments as we wrap up today's session?
Well, I guess the only thing that I would say is the message that I tried to give here was that that everyone should somewhat share in that optimism that I have, that we have an improving treatment landscape, in particular at the moment for scleroderma interstitial lung disease, but that in turn will improve and lower the risks of WHO group 3 pulmonary hypertension. We already have some pretty good medicines for WHO group 1 pulmonary hypertension, the pulmonary arterial hypertension, and that field is not standing still either. That field is moving along with new things. So I'm very optimistic about the future, and the key thing is that if you're going to share my optimism, it's important that we don't lose track of where your disease process is at. So all this screening stuff, which can seem pretty onerous and sometimes seem kind of silly because you're like, well, I was about the same as last year. Why do I keep doing this? Well, it's so that we don't miss it and have you get sicker than you would ever have to be, because we can do something about it. So that's my message. And for the time being, we all have to hunker down a little more than we'd like to, but I'm confident that that too will come to an end at some point where we get some treatments for the coronavirus and hopefully then start getting some good vaccines. I think that's going to happen too.
Well, excellent. In closing, I would like to thank Dr. Molitor for sharing his time and expertise with us today. Thank you to our attendees that logged in or dialed in to today's event, and special thank yous to our Diamond National sponsors, Actelion Pharmaceuticals US and Boehringer Ingelheim, and our corporate sponsor, Corbett Pharmaceuticals. We will be hosting the summer series weekly. Next Wednesday, August 12th, we will have Dr. Carol Fagali-Botzowick of the Medical University of South Carolina hosting a virtual activity for our kids. Fun Science, how to extract DNA from fruits. So please stay connected with us through our website, scleroderma.org, and our social media outlets to stay informed for our virtual university patient education summer series, and as well as all the great chapter events that are happening now across the country. This will conclude today's webinar. Be well and have a great day.